All right, thanks very much. I'd like to start off just by giving you a little bit of a background. So, Peninsula Health comprises of a fairly large geographical area in Melbourne. It consists of both metropolitan, semi-rural areas. We have 2 hospitals, 4 community health sites, and we also have a higher than average proportion of older adults living within our catchment. Despite that, our alcohol and other drug services noted that we weren't seeing many older adults in our AOD treatment services, only a handful each year. And so in 2009, we established the Older Wiser Lifestyles program, which is Australia's first older adult specific treatment service in Australia. I do notice the similarity with the Wiser Older and the Older Wiser, and would like to point out that we were around in 2009. We provide early intervention, treatment, harm reduction, and we've gone from seeing 2 to 5 clients aged 60 and over per year to, in 2014, we saw 141 people aged 60 and over. So I guess that points out that an absence of evidence is not really evidence of absence. And that's going to be my theme today, and probably touch on many of the themes that have already been picked up already. So I'm going to look at what's the rationale for screening older adults, looking at what some of the issues are to consider when screening older adults, and explore the tools that are available that have been validated or at least explored among the older adult population. So in terms of looking at the rationale for screening older adults, some of this has been covered already in terms of patterns of use, prevalence of use, and so this is just another way of graphically representing that there's a positive linear functional relationship between ageing and frequency of drinking. So this is 3 years worth of National Drug Strategy Household Survey data overlaid with age as the x-axis and proportion of people drinking on a daily basis as the y-axis. In terms of the National Drug Strategy Household Survey data, the most recent survey indicates that between 10 and 18% of older adults aged 60 and over are at risk of experiencing long-term harm, which is defined by the NHMRC as drinking 2 standard drinks per day. And between 3 and 7% of older adults had experienced at least one occasion in the past 12 months that placed them at risk of experiencing short-term harm, defined by the NHMRC drinking guidelines as having 4 or more standard drinks per day. Though it's likely that this data is fairly conservative due to some of the things that we've already heard about before, but I'd like to throw a new idea into the ring as well. In our experience, older adults don't have a really good grasp on what a standard drink is. And of course, the National Drug Strategy Household Survey asked them how many standard drinks they've been having. And just to give you an example of this, a couple of years ago on the Frankston Freeway, there was a huge billboard that had 2 glasses of wine on it, and it said 1 + 1 = 3, highlighting that if you buy a glass of wine out at a restaurant or a pub or a club, that they're pouring it to 1.5 standard drinks. Not one single participant of the AUDIT program was able to understand what that sign was about, so it was clearly wasted education for that particular cohort. Celia Wilkinson and her colleagues at Curtin found that older men underestimate their consumption by 32% of a standard drink, and older women underestimate their consumption by 16% of a standard drink. So they then recalculated the 2010 National Drug Strategy Household Survey data and found that between 5 and 12% of older adults are at risk of short-term harm, while 30 to 35% are at risk of long-term harm. In addition to that, we've talked about metabolism as well, and the NHMRC guidelines actually state that older adults should drink less than the guidelines that are provided for younger adults because the threshold for at-risk drinking decreases with age, though they don't provide any specific recommendation. The reason for this is that, as we've talked about already, metabolism, and so older adults are more likely to have impaired motor skills at lower levels of use, and there's consequently an increase in risk of injury, falls, accidents. It exacerbates the symptoms of a range of medical conditions that they might be concurrently experiencing, including diabetes, hypertension, dementia, cancer. It can exacerbate gastrointestinal bleeding and other gastrointestinal disorders. Older adults are likely to have reduced functionality, and that in turn reduces the threshold for their risk of experiencing harm, and as we've already sort of touched on, they're more likely to be taking a range of medications. So in our study, looking at the Australian Alcohol-Related Problems Survey, which I'll talk more about a little bit later, we were looking at a general community sample, and 92% of participants reported to be taking at least one medication that could be affected by alcohol. And in the Older Wiser Lifestyles program more generally, in the treatment service, most of our participants, most of the clients are taking somewhere between 3 and 5 medications that interact with alcohol, and we will often see people who are taking more than 9 medications that are likely to interact with alcohol. In terms of the prevalence of harmful alcohol use and dependence in Australia, I think it is a little unclear, and I'll go back to my earlier comment around absence of evidence not being evidence of absence, because I don't think we really understand from the research that's being conducted at the moment what the prevalence of harmful alcohol use is. I mean, we do know that older adults are underrepresented in AOD treatment services, so 0.77% of people accessing treatment in Australia between 2003 and 2008 were aged 65 plus. And we do know that there's these 2 clear groups of people that are experiencing harmful use or dependence that's been touched on already. The early onset group who have reacted to something typically that's occurred as part of the ageing process, so retirement, loss, all of those sorts of things that have been talked about already. This group tends to have poor health, sorry, I've got myself mixed up. Early onset are the people that have been around for a while. They have good knowledge of the services, so they've been experiencing problems with their alcohol use for a long period of time. They tend to consequently have poor health, and they also have low self-efficacy because they do know where to get the services, but they've already been through them 15 times. And so they have a low sense of self-efficacy in terms of being able to achieve a positive outcome. Contrast that with the late onset group, which is the more reactive group. And these individuals tend to have less knowledge, and so they're going to be less likely to attend traditional AOD treatment services. And they perceive their issue to be that they're much more sensitive to stigma around the issue of alcohol use and alcohol dependence. In addition to this, it's touched on already that there's some diagnostic issues. So if we look at substance-related harm in the DSM-5, many of the criteria don't really apply to older adults. So failure to fulfil major role obligations at work, school or home, or the person's retired. Persistent or recurrent social and interpersonal problems. They may actually be socially isolated already before experiencing the alcohol-related problem. That important social, occupational or recreational activities are given up or reduced. Again, the person may be disengaged from some of those social activities, and use in situations in which it's physically hazardous, which when we think about younger populations, we might be thinking about drinking in situations where it might involve violence or those sorts of things, where in older adults the situation's actually flipped around, and in fact probably the most harmful situation in which an older adult can drink in is their home, if they live alone, because if they have a fall there's nobody there to assist them with that. And so in our program and some of the harm reduction we do, we try to get people that are drinking at home to drink out at RSLs and social venues, so if something does go wrong, there's more assistance available. So in terms of other drug use, we've touched on the misuse of pharmaceuticals, and you can see here from the National Drug Strategy Household Survey that there's a bit of a spike in the 60 plus group. In terms of recent use of illegal drugs, 7% of 60 plus and 12% of 50 to 59. And I think what's been really pointed out today well is that it's that 40 to 49, 50 to 59 group that we really need to be looking at to start planning for the services of tomorrow. In terms of treatment data, so breaking down that AUDIT data from 2003 to 2008, there was 867 people who received AOD treatment that was 65 plus, representing 0.77 of overall treatment. And alcohol was the primary drug that people were seeking treatment for, followed by nicotine, benzodiazepines, cannabis, codeine, morphine, amphetamine and heroin, quite low at the bottom there. I guess it's difficult to know how valid that data is, given that we're only looking at 0.77 of the total data set, but it does correlate quite well with our data set from last year, which showed again alcohol to be the primary presenting drug, followed by benzodiazepines, cannabis, and we did have one person seeking treatment for heroin. So in terms of the barriers to identification, the difficulty of screening with older adults is that most health professionals are reluctant to screen for alcohol and other drug use issues among the older adult population, because it's very difficult to conceive that the lovely gentleman or the lovely lady sitting on the other side of the consultation desk actually has an alcohol or other drug-related problem. There's often a belief that people need to be heavy drinkers before alcohol is considered a problem. So if they're having a few drinks, then that's fine. As the old saying goes, you don't have a problem until you're drinking more than your doctor. Symptoms are perceived as age-related or medical or manifesting from medical problems rather than from alcohol use. And this is really problematic in terms of treatment, because often the symptoms will be, the doctor will attempt to treat the symptoms. The symptoms don't resolve because the symptoms are being caused by an underlying alcohol or other drug use issue. A good example of that would be gastrointestinal symptoms, where the patient's prescribed a medication to manage that. The condition's not getting better because it's not getting better because it's the alcohol that they're drinking that's causing the symptoms in the first place. So based on what I've said, I think all older adults should be screened as part of a regular health check. And there's really only a couple of goals to screening. You want to identify both the at-risk individuals and those that are harmful, engaging in harmful use. It needs to be quick and dirty. You don't want to use too much patient and staff time. It needs to be in the context of a supportive and professional relationship where there's existing rapport. And most importantly, as was highlighted by the past speaker, it needs to be linked to intervention referral pathways. There's no point screening all these people just for the sake of screening them. So I'm going to go through some of the screening tools now that are available, and I'm going to talk about some of their psychometric properties with a bit of a focus on sensitivity and specificity. And in case you aren't all psychometricians, I thought I'd give a little bit of a background to understanding what that means. So if we've got a psychometric tool that has a sensitivity of 90% and a specificity of 40%, well, sensitivity is really about finding out how good is this tool at picking up the true positives in the population, whereas specificity is about how good is this tool at not picking up on false negatives. How good is this tool at not picking up on false positives? So with my little example here, if we're screening a population of 1,000 and 100 people in that population have the problem that we're looking for, and the tool has a sensitivity of 90% and a specificity of 40%, then we would end up screening positive 150 people. 90 of those would be true positives. They're the population we're trying to screen, and 60 of them would be false positives, people that have been screened that don't actually have the problem that we were screening for. So with that in mind, starting off with the cage. The cage is probably the easiest and simplest tool to administer because you only got to ask 4 questions. You ask the person, have they recently tried to cut down? Have other people been concerned about their drinking? Have they felt guilty about their drinking? And have they needed a drink first thing in the morning over the past 12 months? And the great thing about it is that it can be adapted for other drugs as well. You just replace alcohol with the drug of concern, and you can easily adapt the cage as a multi-purpose screening tool. So it's quick, it's adaptable. One of the problems with it is it's not age specific, and it doesn't assess for at-risk drinking. So the point of the tool is to identify harmful and dependent use. In the older adult population, the cage has poor and variable psychometric properties using the cutoff score that's recommended, which is 2. So the sensitivities have ranged between 15% and 70%, while the specificity has ranged between 82% and 100%. Just looking at that, just in general, as you decrease sensitivity, you often increase specificity, and as you increase sensitivity, you tend to decrease specificity. If you reduce the cutoff to 1, then it seems to perform quite a bit better. I still wouldn't say it's a really good performance, but now we're seeing sensitivities of between 60% and 98%, which is quite good, and specificities ranging between 48% and 100%. Though there were 2 studies that have found the cage to have good psychometric properties when a cutoff score of 2 was used. They found sensitivities of 82% and 83% respectively, though the population they were looking at was veteran affairs. And so within that population, there was likely to be a larger subgroup of people experiencing alcohol-related problems, and so that's probably why they found that. So I guess the summary from the cage then is it's a quick tool to use. If you reduce the cutoff to 1, it tends to work reasonably well in the community population, but if you're screening in a population where you're expecting to find a high incidence, then you might like to keep the cutoff as 2. The Michigan Alcohol Screening Test is an older adult specific test. It's 24 items that were specifically designed for older adults. 24 items takes a bit longer to administer them for. It doesn't assess for at-risk drinking again. And with its recommended cutoff score of 5, the psychometric properties are quite variable, with sensitivities ranging from 50 to 70% and specificities ranging from 81 to 90%. However, when a cutoff score has been lowered to 3, those improve so that we see sensitivities of 64 to 86% and specificities of 61 to 79%. So the AUDIT tool, which is probably the most well-known screen for alcohol use, assesses for both at-risk and harmful use. It's seen as one of the gold standards. It's relatively quick to use. However, in the older adult population, it hasn't been found to have good sensitivity. The sensitivities have ranged from 28 to 66%, and many of them have been in that very low range. However, if you just use the first 3 items of the audit, it's much quicker. You can use it to assess again for both at-risk and harmful use. And if you use a cutoff score of 3, it's been found to have very good psychometric properties. So sensitivities ranging from 81 to 100% and specificities ranging between 81 and 86%. Probably one of the only limitations of the Audit C, I think, is that it doesn't assess for other drug use. And so as we see the population changing and service planning, it will be important to screen for other drugs. And it's also not comprehensive in that it is very quick, but it doesn't consider any of the age-related specific factors that we've been talking about today. Oops. The next tool I'm going to talk about is the Alcohol-Related Problems Survey. This was developed at UCLA. It's an age-specific tool, and it works on 100 algorithms that examine the person's medical history, their medication use, their gender, any symptoms that they might be currently experiencing, their current mobility. We've adapted it for use in Australia. And the adaptation was twofold. One, it was about changing the medications and the medical terminology so that it was Australianised. And secondly, it was around altering the algorithms so that they took into account a 10-gram Australian standard drink, because a US standard drink contains 16 grams of alcohol. So that difference, particularly among this population, added up pretty quickly in terms of its effect on the classification. So we've been using the A-ARPS as a bit of an e-expert model, so the acronym being electronic screening, brief intervention and referral to treatment. There's an example of that in the picture here with one of the nurses from the AL program doing the ARPS screen with a patient in a GP clinic. So people access it either via iPads that we've placed in GP clinics across the Mornington Peninsula, or they can access it online, and when they do, they agree to the conditions, which include our clinician contacting them if any significant issues are identified. I particularly like the ARPS because it's a really soft approach. It is the con to it is it does take a bit longer to complete compared to some of the other tools, but it's a really soft approach. It starts asking them about their health conditions, then it talks about their medications, and by the time you've got through all of that, you've built good rapport with the client, you can start talking about their alcohol use. It then provides the participant with a report highlighting what the different classifications are. And that report can also be used as a bit of a lab report for the GP. So the report can either be provided directly to the participant as a minimal intervention, or provided to a GP or other healthcare provider who can then use that to develop a brief intervention. And the report tells them what their classification is, why they've been classified the way that they have been. It talks about so in this case, this particular person has stated that they're taking 3 to 5 prescription medications, and the combination of medications that they're taking are harmful. And it also looks at their health conditions that they have, which could be risky when associated with alcohol use. It provides them with some information on how they might reduce their drinking, reduce their risk anyway, so some harm reduction advice. And it also provides some guidelines for them around low risk drinking, determined by whether they have any health problems and whether they're taking medications. The final tool I wanted to talk about is the Assist, which again is another gold standard. The advantage of the Assist is it assesses for both alcohol and other drug use. Like the ARPS, there are computerised versions available which make administration quite easy. One of the problems with it is, though, it hasn't been validated among older adults. However, it has been examined among older adults qualitatively by Kathleen Ryans from Victoria. What she found was that is in particular in 2 of the questions, so it's a 6-item tool that looks at a range of different alcohol and a range of other drugs, that the item 5 tended not to be particularly helpful because of the decrease in those roles in old age and consequently underreporting, and suggested to adapt it to ask about the impact of functioning on activities of daily living. And the 6th item, which is whether the person whether concerns ever being expressed by a friend, relative or other about substance use. And again, the problem that I talked about earlier with reduced social connections in older age, and the person may underreport. So she recommends that if you're using the Assist, you adapt it to ask about concerns ever expressed in their lifetime. So they're just some key references if the slides are going out to people afterwards, and thank you very much.